you. I want to welcome you today to our special topic today on senior women's health. Do you still need your gynecologist? And before I introduce our presenter today, Dr. Serese Smith-Haxton, we're going to go ahead and do our virtual journey around the state, and we will start with Kansas City. Good morning, Kansas City. I reversed the order. Normally I start at the farthest part of the state, southeast Missouri. So I thought, well, let's just throw for a loop this morning. Let's go the opposite way. Kansas City, here we come.
Their microphone is muted.
Unmute your microphone, please. Well.
Wait till Tyrone gets back in the room there or somebody.
What I can do, I guess I will go back to the original order. Let's just start with southeast Missouri. Oh, we're about to leave. Good morning. Kansas City, can you? Yes, we are, Kansas City. Can you introduce yourself? I see you're still in the process of getting yourself together, but Kansas City, would you please introduce who's in the room?
Can you hear us?
Yes, we can.
Okay, okay, starting with you.
Me? I'm Irma Crow. Hello, did you hear me?
Yes, ma'am, we did.
Okay. I'm Curtis Smith. I'm Cleora Kozar. I'm Hamid Abdullah.
David Abdullah.
Byron Ashford.
Watson Jackson.
Jr.
Watson Jackson Jr. and Miss Joanne Smith.
Is that everyone from Kansas City?
So far.
You have some more comments.
All right, well, what we're going to do, we're going to keep it moving to stay on time. So we're going to go ahead and we will start with Central Missouri. Please introduce yourself. This is Central Missouri. At the moment, we're introducing ourselves, and some of you need to mute your mics. Ms. Alester, would you mind assisting with the mic to make sure it reaches each person? Sure. Just speak into it.
Oh, okay. I'm Mel from Jefferson City, Missouri. Bonnie Giles. Shirley Whitmore, Jefferson City, Missouri. Vicki Myers. I Lester McRoberts. Benita Jackson.
Mary Simmons.
Jackie Jackson.
Pamela Donner.
We are good for Central Missouri. Let's keep it moving to St. Louis. St. Louis.
Hello, how are you?
We are fine. How's St. Louis?
Oh, good, fine.
Good. All right. Would you mind just introduce yourself?
Okay, this is Shirley O'Connor. David Smith. Shirley. Gary Dodd. Harold. John. Peter.
Is that everyone from St. Louis?
Yes.
All right, thank Thank you. Well, let's keep it moving. Let's keep it moving down the virtual highway to Sykeston, Missouri. Sykeston.
Carolyn Hollowell. Priscilla McDonough. Doris Harris. Billy Longstreet. Bernice Williams. Mirabelle Jefferson.
That's it, precise.
All right, thank you, Sykeston. Let's move down to Carruthersville. Kansas City, you need to mute your mic, please, and we'll come back. Miss Adrian Hunter, are you there in Carruthersville?
Yes, we are here. The people are just coming in. We're here.
Good. And so what we're going to do, we will go ahead and get the program started. Our presenter is here today. And so we will probably come back, and maybe if we have time, we'll just introduce who is there. Is
Okay,
that fine?
that'll be wonderful. They're
Okay.
coming in now. They're
Okay.
getting situated.
All right. Not a
Thank
problem.
you.
You are-
We'll be waiting on you guys.
Good. At this time, it is certainly my pleasure to introduce to you our presenter for today, Dr. Serese Smith-Haxton. She hails from Kansas City, Missouri. She and her husband, Chris, have 3 children active in sports, music, and academics. Dr. Smith-Haxton has a love for music, dancing, singing, and also is skilled in designing and making jewelry. She earned her medical degree from the University of Missouri, Kansas City School of Medicine, and completed her residency at Truman Medical Center, St. Luke's Hospital. The areas of special interest are treatment and management of polycystic ovarian syndrome, treatment of endometriosis and menorrhagia, treatment of uterine fibroids, minimally invasive surgery and sterilization. She also is board certified through the American Board of Obstetrics and Gynecology. Without further ado, please welcome Dr. Serese Smith-Haxton.
Good morning, everyone.
Good morning.
So today's topic I'm going to talk about is, do you need your gynecologist? Well, of course I'm going to say yes. I like a little job security. But more importantly, you definitely need your gynecologist. We're definitely talking about the care of a vastly growing population, and that is the women of age 50 and greater. Yes, 50 is just a number, but it is a number that's right in the middle of that age range when hormonal changes will and potentially affect you for the rest of your life. Now, I didn't really want this to be a big PowerPoint presentation. I didn't want you to have 50 billion handouts. So we're going to do this kind of almost like a virtual visit to my office. And that way we can have some questions and answer sessions as we go. You know, the biggest thing that I want patients to understand is that society has changed, so has the medical community. So things are a little bit stratified with developing diagnostic procedures and a zillion new medications out there to take care of high blood pressure and cholesterol. You're not always going to get your gynecologist to take care of that. So we still do need the help of that primary care provider. We don't have the little house on the prairie kind of atmosphere where your primary care doctor does everything. It is very rare and unusual that you'll get your family practice doctor to take care of you when you're having female issues, as they call it, whether it's irregular bleeding or even do a breast exam. So in order to not compromise the care of the female, you may have to see several different specialists. It's important for us to see those specialists because we know a lot about one thing so that we can take the best care of you. So the one thing that's always ingrained in our brain is that every year we need a pap smear. Well, that's not necessarily true now, but let's say your virtual visit to see me is because you need a well woman exam or a pap smear. And so what am I going to need to know at your visit is all of your history. I want you to bring in your medication list and their doses. I want to know about your sexual history, your partner's history, your medical history, your surgical history, your social history, your pregnancy history, your menstrual cycle history, your family history. And I know you're saying, I'm tired of all this paperwork right now. There's too many questions. I can't remember all those things. My family doesn't talk about their health history. And I can't read those questions because my eyes are bad now. Okay, you're thinking, okay, she's just being mean, having me answer all these questions, but I am already thinking in my head and formulating ideas of what we need to focus on in your visit, okay? So, when you come to my office, we do the evil thing. That's make you step on the scale, okay? You know, no one ever complains when we take their blood pressure. No one ever complains about us checking your height. But as soon as you step on that scale, we hear about it, okay? But what we're looking at is how your body is shaped. We want to know if you used to be 5'10" and now you're 5'2", okay? And then we'll have you leave us a urine sample, which you've been dying to do for a long time because you can barely hold it anymore. So that is something we also would like to know. So let's talk about what you really came here for. You think you need a pap smear. Well, recommendations for pap smears has changed over the last few years. Number one, we don't do pap smears on young girls anymore. So when your daughters and granddaughters are 16 years old, they really don't have to see me unless they're having issues with their bleeding. Typically, we don't start pap smears now until you're 21, unless there is a little promiscuity, I'll say. That's probably the best thing we can do for our young patients so that we're not subjecting them to unnecessary procedures. When we do pap smears now, we're also checking for that virus called the human papilloma virus. You probably know it as the wart virus. Yes, it's the virus that can cause warts on your hands that people talk about, or warts on your feet. But out of those 100 different types of that virus, there are 30 or 40 of those that can cause problems in the genital area for females. So when a 50-year-old woman comes to my office and she hasn't had a pap smear for a long time, I'm going to do her pap smear, and I'm going to check for that high-risk HPV virus as well. And if that is all normal, and she hasn't changed her partners, she doesn't necessarily need another pap smear for 3 to 5 years. Now they're also saying that we can stop pap smears at the age of 65 if you've had several consecutive normal pap smears without any change in your sexual history. So when I say change in your sexual history, you know, they talk about cougars now. There are a lot of women that have younger boyfriends, okay? And there's a lot of us women that are having to deal with the fact that that little blue pill gets passed out a whole lot to our partners, and that's Viagra. Okay? So when you're talking about my pap smear getting done and things not being normal down there, it's because of those hormonal changes that we'll see as we go through the change or menopause, okay? So I'm already thinking, you're telling me that you're not very active because it hurts too much, or that you leak urine when you have sex. Those are things I'm gonna focus on when I do your exam. So we've started your exam. I know your blood pressure. I know your weight. I know your body mass index. And so what I want to focus on is obesity. which unfortunately is the most devastating epidemic that we're dealing with in this country right now. It can cause increased risk for heart disease, diabetes, sleep apnea, incontinence, musculoskeletal pain, joint pain. So I'm going to be looking at your weight and your blood pressure and deciding that I want to check your glucose level and rule out diabetes, or your cholesterol level, or your kidney function. Now, I may ask for those labs, and once again, I might be sending you to see your primary care doctor, because he will know the new medication, the new options for treatment if I find there's diabetes, or if I find there is a cholesterol issue. I might send you to our diabetic educator, who will talk to you about diet and exercise and the reasonable ways to do weight loss. Our next thing on our exam is, we might feel your neck, feeling for lymph nodes or an enlarged thyroid. Because once again, the thyroid is that one organ in our neck that controls our whole metabolism. So if it's enlarged, I may add an ultrasound. I may add a blood evaluation to see if your thyroid's working effectively. If it's not, because a lot of us wish that's true, that's why we have gained all the weight, replacing that thyroid may help with your care. So next, we listen to your heart. Make sure we don't hear anything irregular. Maybe we might need to get an EKG. Maybe we send you to our friend the cardiologist to have them evaluate more. We listen to your chest, and we wonder if you have asthma or if you have COPD. And that leads us to smoking. So in my head, I'm thinking, okay, she's a smoker. What other thing that triggers my brain right then is her risk for osteoporosis. As you know, when you go through the change, there are hormonal imbalances where your hormones are up and down and all over the place. You're having hot flashes, you can't sleep, you're going to kill your husband and your children. Your bleeding may be irregular, it may come and go, you may be heavier. All those changes we may see. And unfortunately, it just may be as your body is changing. So I worry about osteoporosis in women who are no longer making estrogen, okay? And that is when you are truly menopausal. And it is worse in women who are thin, smokers, and Caucasian. Now, a lot of people don't think about the fact that estrogen protects your bones, because it does. And so we worry about people falling and breaking their hips. And about 20% of women who fall and break their hip, unfortunately, end up in a long-term care facility. And that's not the way we want to live our life. It is not about a quantity of life, it's about a quality of life. So at the age of 65, we may ask for you to get a bone density scan done. Or if you do have a history of, I fell and broke my wrist, we may ask for that even earlier, just to make sure that you don't have osteoporosis. Because we have a whole wide variety of medications that we can give to treat osteoporosis. We talk about calcium intake. Everyone who's 50 and over and menopausal should be getting about 1,500 milligrams of calcium every day in their diet. Diet alone should replace their calcium. It's okay if you take supplements, but the best way to get any of your vitamins and supplements is through your diet. We also want you to get vitamin D with about 800 international units to about 1,000 international units. And that does not mean go out and suntan. Okay? That means through healthy diet. Okay? My favorite thing to tell my patients is Activia. It sounds silly, but it is fermented dairy, which gives us probiotics, which is good for our intestinal system, and it has calcium in it, and it helps our bowel function. So kill one bird with one stone. So that's how we do that. Okay? So next we go to the breast exam. And there have been so much discussion on when do we start screening mammograms. So once again, we go back to that family history that I asked you about and those tons of questions that you got frustrated about filling out. to see if you have a sister, an aunt, and a mother, and a grandmother that have breast cancer. Because my focus is on whether you have a genetic increased risk for breast cancer. So whether you are 50 or 35, you might need further evaluation. The newest thing that's out there is a genetic way to check for that abnormal gene. In our office, we do it the CSI version way, in that we get your genetic cells from inside your cheek by doing a little spit test with some scope, and we send it off to a lab. And what we're looking for is an abnormal mutation of, they call it the BRCA or the BRCA gene, and that is associated with an increased risk for breast cancer and or ovarian cancer. So if we know that you are positive for that gene, and you don't want to have definitive therapy done, maybe instead of that mammogram every year, you get an MRI of your breast. There are some women that choose to go ahead before they get their breast cancer to have their breast removed. So then I'm sending you to my general surgeon friends, and they're sending you to the plastic surgeon friends, so that you can get the mastectomy done and the augmentation all at one time. If you're higher risk for breast cancer, we talk about maybe starting medication that may prevent problems later. And one of them is tamoxifen, and the other one is something called Evista. Now, Evista goes way back to that osteoporosis one, because it's actually a treatment for osteoporosis, but it has a protective effect for the breast. So we talk about all those things, and we talk about hormone therapy. We worry about breast cancer and hormone therapy. So if there's an increased risk, or you had breast cancer before, we're not going to be talking that much about hormone therapy, but we do want to address all your issues that you're having as you go through those hormonal changes. So it's kind of a full circle. Women are wired, and everything is connected together. So next is your abdominal exam. What we're looking for is liver problems, gallbladder problems, which unfortunately estrogen increases your risk for gallstones. The biggest thing is an enlarged uterus. I had a patient come in to me one time because of her beer gut, is what she called it. And it actually was her uterus that was all the way up to her xiphoid process. Uterine fibroids are very common in African American women. Sometimes you can have them and not have a problem with them, but they can cause back pain, pelvic pain, heavy bleeding, irregular bleeding, problems holding your urine, problems with your appetite because they've actually been pushed up. So those are things that we're looking for when we do your abdominal exam. If you're tender, we worry about your bowel functions, whether you have constipation or diarrhea or irritable bowel. So along that line, at the age of 50, we talk about the evil C word, colonoscopy. Okay. Every 10 years, you should have a colonoscopy. That is if they don't find anything. Now, some people don't like the idea of having a colonoscopy done. So sometimes we'll send you home with the little poop cards, as we call them, and you mail them back in. But those aren't as accurate as having a procedure where we actually look on the inside. So here I am sending you to my friend, the gastroenterologist. He may say, okay, you don't want the colonoscopy? Maybe every 5 years we can do a flex sig or a barium enema. So there are other options for evaluation of the colon. Why are we worried about colon? Because unfortunately with menopause, colon cancer increases. So now we're down to the arms and the legs, and we talk about swelling and varicose veins and treatments for those, and we look at your bones and worry about osteoarthritis or rheumatoid arthritis. I look at your skin. I'm looking for any type of abnormal mole, ruling out melanoma. I look for any signs of any type of basal cell, squamous cell cancer. I'm actually looking also at your neurologic exam, making sure that your grip strength and your gait and your balance are all normal. And I'm also looking at your mental status. Unfortunately, with menopause and perimenopause, women will have an increase in depression, mood swings, and we also worry about Alzheimer's. Unfortunately, Alzheimer's is significantly higher in women after they go through menopause. So now we finally get to the female exam, the one thing you really came in to see me for. And what I'm looking for is all those changes that can happen when you lose your estrogen, okay? We're talking about lack of hair. We're talking about thinning of the vagina. The vagina is the hammock that holds your bladder. So that's why when you gotta go, you gotta go. If it's weak because it's so thin without estrogen, you have problems with not holding your urine. You may have problems that when you laugh, sneeze, or cough, you lose urine. We talk to you about exercise. Well, you can't jump or exercise because every time you do that, you leak. That's part of that as well. And this is where you can blame your children, because pushing babies out increases your risk for prolapse. And that's when your bladder falls, or your rectum pooches up, or your uterus starts to come out. Okay? That's all because of childbirth. And that support is decreased when you lose your estrogen. So we're looking at all those things. We're looking at, is it so thin that's why your partner is bugging you and you don't want to do anything? It's because it hurts too much. And sometimes we talk about helping you with that relief with medication. We're filling the uterus. We're filling and hopefully not filling the ovaries. As you become menopausal, those little ovaries that made your estrogen are not making it anymore. They get really, really small and they move way, way up. Okay? So if I'm doing your exam and I feel the ovaries, that's a cause for concern. So that's when I send you to get an ultrasound done. That's when they look to see if there's any masses that can be caused or associated with ovarian cancer. So let's talk about all the hormonal changes. I have several patients that come in and their biggest fear is that whole WHI study that years ago came out and said that hormones are bad for you. Well, if hormones are so bad for me, why did I have them for 50 plus years? Okay. The average age for menopause is 51. But we can go through those ups and downs of our hormones being everywhere for 4 years before it even happens. So we have to learn to listen to our patients. Our patients who are 45 years old and come in and say, okay, my periods are happening every 2 weeks. Or I am soaking through a pad and a tampon in 30 minutes. I am going to kill my husband and my children. And then she's crying in the corner the next moment. A lot of people don't realize that back in the 20s and 30s, women at this time were in sanitariums because their hormones were causing them to have issues with depression and rage, defiance. Back in those days, you didn't defy your husband. So we have to deal with those issues. We have to deal with the hot flashes. And the hot flashes that wake you up at night, so then you can't go to sleep, which makes your mood even worse, which doesn't help with your diet, because if you don't sleep enough, then your diet doesn't go well. All connected, full circle. We don't always preach hormone therapy anymore, okay? You come in, we look at all your risk factors. We may talk to you about, okay, let's kill a few birds with one stone. You're a little depressed and you're having hot flashes. There is actually some good studies out now that show us that antidepressants such as Paxil and Effexor are very good for hot flashes. And they're also very good for stabilizing your moods. The other thing we learned from that whole WHI study is that hormones is not a vitamin. It is not something that you have to take every day for the rest of your life. We are supposed to use the lowest dose for the shortest time. And you can stop it and realize, oh, no, I'm not good with this, and start it back again. Our concern was heart disease. What they failed to tell most patients when they did that study is most of those women had been without their estrogen for at least 10 years. In the first 2 years of starting that whole perimenopausal change, your cholesterol and your lipids and your fats all change. So those women who said, oh, I want to do this study, that's some money, walked in that door with heart disease already. You give them estrogen, of course they're going to have strokes and heart attacks. Our biggest concern is that women need to take care of themselves as far as keeping their cholesterols in check. So when you give them estrogen, it is not going to fix your cholesterol. It actually increases your risk for heart disease. So the way they could have made that study the best was not very cost effective. Technically, every patient that came in there should have had a cardiac cath looking for existing disease before they gave them hormone therapy. Now that study only checked on Premarin and Prempro. We have a whole wide variety of different types of hormonal therapy. The same hormones that are in birth control pills now, we can do them in lower doses for women that are menopausal and having symptoms. And a lot of women don't realize that birth control pills actually are very beneficial. They decrease your risk for ovarian cancer. They decrease your risk for uterine cancer and endometrial cancer because they keep everything in check. So we have a tendency to use those type of hormones now to help women out. And then there's some women who are all natural and they want to go to pharmacists and have something formulated for them, and that's just fine. If you don't want to take a pill, you can take it by lotion or put a patch on or put something under your tongue. I mean, there's a wide variety of options for hormone therapy now. We even have a medication out now that is sort of like an estrogen. It was meant to help with osteoporosis, but the first thing they noticed is that it helped with vaginal discomfort. So now we have this medication out called Ospina that actually makes, as they quote, the vagina happy. And yes, there's still that risk with any hormones of blood clots to the legs, to the lungs. So as I'm seeing you at your exam, I'm looking for all those risk factors before I make a decision on what I'm going to do. Our goal is to get you to come in, to streamline you to where you need to be, to make sure that when you leave, all your questions are answered, that all your health issues are being addressed and evaluated. I may not be able to take care of everything, but you will be educated on the right way to take care of everything and who you need to see before you leave my office. Now, I don't do vaccines, but at the age of 50, we still recommend every year you get your flu shot, okay? They recommend that if you have asthma or any heart disease, beyond hypertension, that you still get your Pneumovax, okay? Otherwise, Pneumovax is 65. And now we get the shingles shot now, too. And the big thing out there is the whooping cough vaccine. A lot of women are getting those whooping cough vaccines because their grandbabies are staying with them. And whooping cough is a potentially deadly infection for newborn babies. So we recommend that patients and all those in the household are up to date on their whooping cough vaccine. You know, when I asked you to fill out all those 50 billion questions and you told me, I can't see it because my eyes are bad, that also triggers me to tell you, okay, maybe we need to see the eye doctor because macular degeneration also increases with age. So then we are cataracts. So So there's a lot of things that you can gain from going to your gynecologist. Yes, we say we're not primary care, we say we are specialists, and we truly are. We're the only ones that can fix it when it's falling out, or help it feel better, or assess you for your irregular bleeding and hopefully put things back into that normal status. But yeah, it's a teamwork effort in order to keep you healthy, and that is our goal. It is not a quantity of life. It is a quality of life. We don't want you in the nursing home at age 55 because you fell and broke your hip and you're senile. That is not our goal. Our goal is to see you at that Lincoln track, running and walking and talking to your friends about what you're doing this weekend. Okay? We want to make sure that you know the safe ways to exercise. And when you exercise, that you're helping your heart and your bones and your brain. So that's the goal of your gynecologist. So from age 50 to 60 to 70 to 80 to 90, you still need to see my bright and shiny face. Any questions?
Let's start with a satellite location. Let's start with Carruthersville. Carruthersville.
Hello?
Yes, we're gonna, do you all have any questions?
No, we don't have any right now. We're gonna knock your back this down.
Can you briefly tell us who's in the room? Introduce yourself.
I'm Paula Coleman. Lucinda Royal. Joyce Morgan.
Bernard Thompson.
Lorena King.
Is that everyone?
Yes.
All right. Well, we will come back to you because later on we have some door prizes. So hopefully you'll have questions as well. Let's move up to
Thank you.
Let's move up to Sykeston. Sykeston, do you have any questions?
A question? Yes. What if you've had a hysterectomy?
Question is, what
About the pap smear.
okay,
If
your
you
question,
had a hysterectomy, do you still have to do a pap smear?
the question is, if you've had a hysterectomy, do you have to have a pap smear? The question is, why was your hysterectomy done? If your hysterectomy was done because of bleeding or fibroids, that is technically a benign condition. You do not have to have pap smears anymore, okay? Now, there are some women that have their uterus removed, but their cervix is still in place. Those women still need to have pap smears every year. Now, if your pap smear was, and your hysterectomy was done because of cancerous changes or precancerous changes that were moderate or severe, then you still have to have pap smears done for a certain amount of time. Now, if it's been done for cancer, definitely, and for about 20 years after that therapy, do you have to have your pap smears done. So a lot of it depends on why you had your hysterectomy.
Thank you.
Mm-hmm.
Good question. Let's move up to Sykeston.
Excuse me.
Oh, one more? Oh, good.
We have another one.
Okay.
Okay. You said something about having to have so much calcium per day. Was it 1,500 or 15,000? What did you say?
1,500. How much calcium
Okay.
every day? 1,500 in divided doses. Don't take it all at one time.
Okay, well, how much of the, in our diet, what in our diet would give us 1,500 units of that?
Tropicana is fortified with iron. If you look at your listings on all your food that you eat, it does have calcium listed on there. Okay? So yogurt, we talked about dairy food, cheeses.
No, I'm not saying what kind. I'm talking about what amount. Like, if you drink milk in the morning and, like maybe like 8 ounces of milk, how many I mean, you just have the classes available, you have to drink to get.
Yeah, that will be on your container. Okay?
Okay, thank you.
Uh-huh.
Any more questions?
No, thank you.
Let's move up to St. Louis.
Hello, I have questions. I have questions here in St. Louis, hold on. Why do the doctors not give you, like estrogen or something to help with it, or put your hot flash stuff?
Could you repeat that, please?
Okay, now, your uterus and ovaries are removed. Why don't the doctors give some kind of estrogen for the hot flashes and everything?
When you have your ovaries removed, it depends on why your hysterectomy and ovaries were removed, whether they will give you estrogen or not. If you have a history of breast cancer, they usually won't give you estrogen therapy. If you had uterine cancer, they won't give you estrogen therapy. There are still a lot of women out there who have a fear of developing breast cancer, so choose not to do hormone therapy. So it is a collaborative agreement between you and your physician of what goals you want, what you want to do, because these are all recommendations. We don't sit on a pedestal and tell you what to do. We can only recommend what to do. So if everything was appropriate, they can give you estrogen if that's what you choose to do. If that's what happened to you and you didn't get estrogen, I can't answer. Why not? Without knowing your medical history. A lot of providers still do estrogen therapy.
It was uterine cancer.
That's why you didn't get estrogen. It's because you had uterine cancer. So then we talk about other options to help you with your hot flashes. Now that could be natural based. I forgot to say that soy is a natural source of phytoestrogens. You can put a quarter cup of soy in your yogurt every day, and that might help with hot flashes. As I was saying, Paxil is a good source of helping with hot flashes. Effexor as well. Paxil even got fancy and repackaged itself in a lower dose. They call it Blvd, and its indication is for help with hot flashes. So that's why you didn't get hormones.
Any more questions from St. Louis?
Yes, we have another one.
I know you mentioned about the bladder falling, about how organs is place. And I just know that there
Could you
To repeat that?
Microphone is too close.
I said that you mentioned that sometimes your bladder and things don't stay in place where you have the hysterectomy.
Yes. Okay. Okay. Let me repeat this to see if I got the question right. Bladder falling after having a hysterectomy, and what are your options for treatment and therapy after that? Is that your question? Okay.
Yes.
Okay, all right. When you have a hysterectomy, it depends on the indications, like I said. And if it is because of that support issue, then we worry about tacking up all those ligaments that used to hold things in place. And yes, if that is not addressed, things can fall. Your bladder can fall, your rectum can pooch up. Your intestines will fill that space where the uterus would be, and that can fall as well. So there are very many different options of how we can treat that. Some women are like, I did surgery once, I don't want to do it again, but this is uncomfortable. But they are 5'2" and they weigh 250 pounds. We'll talk about weight loss, because anything that increases that pressure in your abdomen will increase the pressure on your vagina and the top of your vagina and make things fall. So weight loss alone sometimes helps with what we call prolapse. We talk about using things called pessaries. Now, back in the day, I actually saw a patient who had things falling out, and her great-grandmother told her to put a potato up there. She didn't take the potato out, and it started to sprout. But that concept that her great-great-grandmother talked to her about is something we call a pessary. And that is a rubber device that we can put in your vagina that holds things up. Now, there's some women that are really good, that they can take it out and clean it and put it back in when they need it. Sometimes I have patients come in every 6 weeks that I take it out and clean it and put it back in for them. And that is a device that actually holds everything up for them. I use it sometimes as well to know what a woman's going to do when I correct her anatomy after it's fallen, to see if I need to use the nasty other word, mesh, okay? We use meshes now to support the vagina and the urethra. There's been bad news about it, but it's actually a very good option. The slings that they use to prevent you from leaking are very small. And what it is there is nothing in the bladder that keeps that urethra closed. It's actually an angle that keeps our urethra from letting urine out. When things fall, we lose that angle, so everything is a straight shot. So we use the sling to tack it up to keep that angle. The issue is that some providers that do these shouldn't be doing these things. Slings are not that dangerous at all. Mesh is not that dangerous at all. What you have to look at is quality of life. You have a patient whose own natural tissue was weak, so it fell. You can use her tissue and try and make it strong again, but it's already proven that it is not going to work. Sometimes we will use biologic things from cows and pigs to simulate that vaginal support. And that does better than using your own tissue, but it still has a failure rate. Mesh is the only thing that can be placed that has a lower failure rate. But the whole issue is a lifestyle change as well. If you're overweight, you gotta lose some weight. If you are working a forklift and moving 100-pound weight lifts, that's gonna have to change. Anything that increases your abdominal pressure can make things fall out. Does that answer your question?
We have another one.
Go ahead. Go ahead.
Both breasts. And I'm 85. When I
We're going to have to repeat that.
Okay. I've lost both breasts. What's that? Yes. And you mentioned talked about going to your GYN. Like, you mentioned ages. Seems like you said 50 something. But I'm 85. What advantage is it to me now? Or should I continue to GYN?
Okay. I think the question she has is because she's already had both her breasts removed, and she's 85. Does she still have to come see me? Is that correct?
Yes.
Okay. Like I said, age 50, 60, 70, 80, 90, you still need to see your gynecologist. Because what we're focused on is everything. Your mind, your body, everything, okay? So yes, we are going to still address your bones and your potential risk for osteoporosis. we're still going to assess your ovaries, okay, if they're still in place, because you still have that risk for ovarian cancer. We're still going to assess the vagina, because we worry about the uterus falling out, the bladder falling down, or the rectum pooching up. So it is still always important to see your gynecologist. We may not have to do a breast exam because your surgeon and your gynecologist are taking care of that, but we may have to take care of some of the other issues that that treatment is affecting.
So many patients are saying that doctors don't recommend seeing a gynecologist after a certain age, and I wanted to.
Well, you know, yes, we stopped pap smears at age 65. They're saying now that we can stop mammograms at 74. I'm not too sure I agree with that thing. But like I said, you are a female. We are female doctors. There are other issues that we will address. It doesn't always have to be about the breast and the uterus. It could be about empty nest syndrome. It could be about depression. It could be about osteoporosis. Okay.
Hey, I have a question. Okay, talking about the bladder falling. Is there any medication that you could get or have the doctor give you to help stop it?
The question is, when you're talking about the bladder falling, is there medication that you can receive to treat that or prevent that? The only medication that you can receive is to treat if the problem is that when you laugh, sneeze, and cough, or you lose urine, or that you can't hold it. There are medications to treat the incontinence portion of it, but when I'm talking about falling, that is a structural problem, and no medication can treat that. So in order to treat that, it's either putting a pessary in, or tacking it up surgically, or trying to strengthen those muscles, because sometimes we will send patients to the physical therapist to help them with that.
Thank you.
You're welcome.
Any more questions, St. Louis?
Yes, one more.
As far as, having still having your ovaries, so this needs to be removed, what is the next step? And in the 52 range for, woman, still have your ovaries.
Could we repeat that, please?
Still having,
Your ovaries, both of them.
and your ovarian to be removed due to, massive bleeding. And that's removed. What is the next step for a woman at the age of 52?
Okay. Let me see if I got this right. You had your uterus removed because of bleeding, but they left your ovaries in. What is your next course? Is that correct?
That's it.
Okay.
Yeah.
All right. So your next course is hopefully at age 52. You were still having bleeding problems when your uterus was removed. So we still don't know if you're menopausal or not. Unfortunately, when you have your uterus removed, you are separating it from those ovaries. So some women will have hot flashes and menopausal symptoms even though their ovaries are in place and still working. So what we might do for you is, if you are having more symptoms, we can evaluate blood-wise to see if you truly are menopausal, and talk to you about how we need to help you take care of those menopausal symptoms, which is those ovaries not working anymore, and maybe do medication therapy with just hormone estrogen, okay? You need to have estrogen and progesterone for hormone therapy if you have a uterus still. But when you don't have it, you just have estrogen to help with all the hot flashes. You still need to have your exams every year because those ovaries are still there. They can still wreak havoc, and that's called ovarian cancer. So that's kind of your next step. If you are menopausal, we still have to address those whole issues of osteoporosis and things like that as well. Is that lack of estrogen that still can make your vagina not happy that we have to address.
Thank you, St. Louis. We need to keep moving, and we will come to, of course, Central Missouri. Do you have any questions?
Yes, my question is in reference to the thyroid.
Okay.
Okay, do they cause swelling in the abdominal area, and do they shrink as you age?
The question is about uterine fibroids. Do they cause swelling in the abdomen, and do they shrink with age? Yes, actually, to all those questions. Fibroids are benign growths of the muscle of the uterus. More common in African American women. Why, we don't know. Sometimes they can cause issues with bleeding, heavy bleeding, pelvic pressure, constipation, problems with discomfort and always having to go to the bathroom all the time. And typically, yes, they are driven by estrogen. So when you go through menopause, they typically do get smaller. So there are a lot of women that walk around with fibroids because it's really not affecting their lifestyle. They're not bleeding heavy. It's not bothering them with constipation, and they choose to do nothing about it. And that's fine if you're not having any issues. Because yes, they typically do get smaller as you get older. The biggest concern is if they're really, really big, it makes it hard sometimes for us to assess your ovaries. And so we may have to get an ultrasound to make sure that the ovaries are still doing good and there's no concerns about uterine or ovarian cancer. So yes, it does cause swelling.
Okay, what type of treatment is recommended for it?
For uterine fibroids, if you need treatment, depends on what the problem is. The definitive therapy for fibroids is a hysterectomy. There are some women that have small fibroids and it's causing heavy bleeding, but it hasn't made their uterus too big. So we do talk about therapies where we just burn away the lining of the uterus so that their uterine lining doesn't listen to all those hormones anymore. So that's the goal, is to lessen their bleeding, but it doesn't treat the fibroids. Sometimes you have patients that don't want everything out, but they want the fibroids gone. So you can actually just remove the fibroids, but there's a 20% chance that they'll come back. And then there is a radiologic procedure. Here we go again, sending you to my next buddy. Where they go in like they're doing a cardiac cath, and they send in little pellets to the bloodstream of that fibroid, and it kills off their blood supply, so then they shrink. So that's also an option. Again, that's called an embolization. Those are your options for fibroids.
What age do you start seeing girls, young girls?
What age do I start seeing young girls? I'll see them at any age if they're having issues. I'll see them because they're missing school because they cramp so much and they're throwing up and their periods are really heavy.
I have a granddaughter that fits that description.
Yeah, I'll see them then. Okay. So I will see young girls for any of those kind of issues as they're coming into puberty and they're having issues with their bleeding. Just because you come to see the gynecologist does not mean you're having pap smear done. Does not mean I'm going to put the speculum in there. But most of those little girls are terrified when they come see me. They're like, oh, my mama told me I had to come. So it doesn't always mean that. Okay, so yeah, I will see young girls who are having pain with ovulation and all those things.
Yeah, she's having a lot of trouble. Thank you.
You address the fact that women that are gone through menopause can live without estrogen, or maybe there's another option. What does that do to your level of testosterone then in your body, and will we start growing mustaches and beards?
That's the issue, okay? We always make testosterone in our ovaries. When we are in our teens and 20s and we start having our periods, we use that testosterone to make our estrogen. And then as we go through the change, that actually means that there's no more ovarian follicles in there to release. And so we don't make estrogen anymore. But yeah, we always make testosterone. And so yes, we will have the issues with the hair. And so that's why young girls who have what we call polycystic ovarian syndrome, they don't ever overcome that testosterone level because of hormonal imbalances. And so that's why they have issues with hair as well, okay? And unfortunately with polycystic ovarian syndrome, it affects our insulin. So it's actually a precursor for adult onset diabetes. So yeah, polycystic ovarian, it's all a hormonal
Is that a
thing.
guarantee if you have the polycystic ovarian thing that you will have higher levels of testosterone? I mean, is it gonna happen for sure? And then
Not all girls will have problems with hair growth. No, not all of them. Not all of them. Typically what is a bit most common is irregular bleeding and infertility.
thank you.
Okay, my question is dealing with, just reverse. She's talking about the mustache and all of this. I know a lot of women who have been on the hormone therapy, specifically estrogen, have opted to get off of it, and they've lost their hair starts thinning. So what is it that you can recommend, that they can do as an alternative kind of, and you did mention some of the natural kinds of drugs or treatments.
The question is, having been on estrogen in the past, stopped, and now we're noticing that our hair is thinner and the hot flashes are still coming, and what our options are. So let's address again. You were on estrogen in the past and did very well with it. And then you chose to stop. You can actually restart if you haven't been off of it for more than a year. You lose that protection that you had for your cardiovascular disease after that year, okay? If you don't want to go back on hormone therapy, then we do talk about natural resources. I know there's a section at Walmart that has estrogen, which is natural hormones. We talked about soy. You still have to have your thyroid checked to make sure that the thyroid is not a reason why your hair is getting thinner, because thyroid disease increases as well, and that can cause issues with the thinning hair. Otherwise, you visit your local cosmetologist and dermatologist and see if they have any other suggestions. But unfortunately, thinning of the hair and hair loss is something that comes along with those hormonal changes associated with menopause.
We have one more question from Central Missouri.
My question is, I had a thyroid problem, and they gave me a radiation isotope, and I have hot flashes. I take medication, but I hadn't took it for, that was in 1985. And then I had a panel done because my mother died from thyroid cancer. And then my doctor started giving me medication for my thyroid. But the hot flashes is kicking my rear end. I just don't know what I'm supposed to do.
Okay. So are you menopausal? Are you still having periods?
Honey, the door has been shut forever. There'll be no more. In or out.
So her question is, long time menopausal, but the change in the course was that she had thyroid disease and they radiated her thyroid, and now the hot flashes are back and it's not fun. Not everybody reads the same book. You know, they typically tell you that it gets better. It may be a rough few years, those first years, but as you get older, usually the hot flashes get better. In your case, the thyroid, which controls our metabolism everywhere, is kind of out of whack, and so your hot flashes have come back with a vengeance. So then we talk about other options potentially. Got to make sure that your thyroid's under control with your doctor by supplementing. And then we talk about maybe other medication, like we talk about the Paxil for hot flashes. They use clonidine sometimes for hot flashes, which is a hypertensive medication.
When they done this and gave me that radiation isotope, I was 40 years old. And once I took that, my period stopped just like that.
Thyroid controls everything. Okay, and so that thyroid controls your metabolism. So a lot of women with thyroid conditions will have irregular bleeding and infertility. And so we have to correct those thyroid issues. And sometimes that will help things back. So essentially without lab evaluation, we can't say that your lack of period was due to really your ovaries doing it, or the fact that you had a thyroid issue. There are a lot of women that go through cancer therapy. Chemo has a tendency to destroy the ovaries as well and cause a early or premature menopause.
Well, I had breast cancer, I went through chemo, that was 25 years of so and so I'm cool with that.
So that's kind of where we are. So we just kind of have to keep you happier and comfortable, and there are other medication options for hot flashes that don't involve estrogen therapy, because no one's going to want to give you estrogen.
No, I can't take it.
Yeah, because you can't take it.
Is not happy.
Yeah. Yeah. But you know, there are a lot of options for vaginal therapy, local vaginal therapy with hormones that's low enough it doesn't get into your bloodstream. It's just for the local effects. And you can do that even though you have a history of breast cancer. Okay? The pill Osphena is kind of like an estrogen. That is still an option, sometimes in women for discomfort as well. I'm not sure if I would use the Osphena for you, but you know, a little bit of local estrogen is not a bad option because it doesn't go into the bloodstream.
Thank you.
I have one question. You talked about the whooping cough vaccine.
Yes.
If you've had whooping cough, would it be necessary that you get that? And can you have it more than once? Whooping cough, that is. I'm told I had that at a very young age.
You can have whooping cough again, okay? So every 10 years, actually, women are going to be getting the whooping cough vaccine because it's packaged with tetanus. So it's called the Tdap. So every 10 years, you should probably get that. So nowadays, if you're in the ER and you're in a car accident and they ask you about your tetanus status, you go, oh, I don't know, it's been a long time. When they give you your shot, it's going to be tetanus and whooping cough put together.
Thank you, Central Missouri. In the essence of Dr. Smith-Haxton's time, we have one more site, Kansas City. Do you have any questions?
Kansas City, do we have any questions? Yes.
I don't think this is a question, but I'm a great grandfather, and it was quite interesting to sit here and I think it added more to my education about female. Thank you.
You're welcome.
Any questions? I think we're satisfied. Thank you.
Well, good. And in response to the gentleman's comment, we will also have a series on men's health. Before we depart, I have a few announcements, but before I do that, please join me in a big round of applause for Dr. Yes.
Deborah, excuse me.
Yes.
We have a question from Crothersville. I think you were supposed to come back soon.
All right, good. Go ahead, Crothersville.
Yes, I would like to ask a question of, you mentioned the shingle shot, and how often do you have to get those? Do you have to have them? I would like to find out on that. The shingle shots.
The shingle shot, I think, is one time. And so usually your primary care doctors will handle that shingle shot. And they usually give that, I think, at starting age 60.
To get it.
Okay.
Are there a certain age limit on the shingle shot?
No, I don't think there's a certain age limit. You know, so you can procrastinate if you want to. Okay.
Okay. One other question I have, What age limit do you have to be to stop taking pap smears?
They say we can stop taking pap smears at age 65. That is if you didn't have a history of severe precancerous changes or cancer of the cervix. Okay? We'll still continue them too with uterine cancer as well.
Okay, is that it?
No.
Okay, I think that's it for Crothersville. Thank you so much.
You're welcome.
Obviously, we're gonna have to invite Dr. Serese Smith-Haxton again.
Yes.
Which leads me into the next two things I need to speak in regards to as it relates to events coming up for the Quality Carter Center. And of course, we will have our senior summer school, which would be June 2nd through the 5th of this year. And we will also have our 17th Missouri Institute on Minority Aging, and that will be from August the 26th to the 28th. Hopefully you will come back and join us for either one of those two events. One more time, please. Thank you. It's June 2nd through the 5th for the senior summer school. Now, before we disconnect, we will have, I hope each site has chosen a door prize winner, and I hope Dr. Haxton can stay for one moment to pull the winner for Central Missouri.
Okay.
All right, so let's go back to Carruthersville. Who's your winner for the door prize today?
Oh, did she say something? Thank you.
You won.
Let's try this one more time. Let's start with Carruthersville again.
One moment.
Okay.
For Crothersville, it's Miss Bernann Thompson.
Miss Bernann Thompson, you have won. It will be a big surprise. Trust me, when I was out yesterday selecting, I couldn't select one. So your prize will be mailed out perhaps, hopefully today. Thank you again, Carruthersville, for joining us. And time flies when you're having fun, doesn't it? So we're going to say goodbye to Carruthersville first. Goodbye, Carruthersville. Bye. Well, let's move up to Sykeston. Who's the door prize winner?
Miss Charlene Hawkins.
Miss Charlene Hawkins. You have nice prizes coming your way. Thank you again, Sykeston. Goodbye, Sykeston. St. Louis. Who's the door prize winner there?
Michelle Manning.
Miss Michelle Manning. Congratulations. Goodbye, St. Louis. Hope to see you all again. And that prize will be coming soon. Our prizes. Let's move to Kansas City. Here we come.
Okay, the winner in Kansas City was Mr. David Abdullah.
Mr. David Abdullah. All right. Hey. Thank you, Kansas City, for participating.
You were welcome. We're done.
Yes, sir. I know. I just said time flies when we're having fun, and this has been a very informative session. So obviously we need to do it.
We appreciate it. So we're going to clap it up for y'all. Thank you very much. Let's go to the team.
Goodbye, Kansas City.
Goodbye.
Born and raised there.
All right. Well, Dr. Serese, would you mind choosing
Was wetland?
Lowen? I'll take that for her. Well, you have some goodies in here.
Thank you.
Well, at this time, thank you for participating in our lunch and learn today. And this is now time to dismiss for lunch.